So, those of you who have been to quality forums before know that one of the highlights of this session is always the debate. Quips, Quandaries and Comebacks, a quality debate in both senses of the term. And what we do is we find a topic that is relevant, and unfortunately there is always one side that is intuitively so appealing and obvious that we have to find people who will debate the opposite. But I think this year, actually, it's not quite the slam dunk conceptually that it has been in different years, because what may seem not to be a debatable proposition, you will shortly learn, truly is. What is our resolution today? Be it resolved that people should have full and real-time access to their electronic medical record. Now, of course, that's a bit of a trick question, since who has one? And what's ever in real time in healthcare? But think out of the box. Imagine there were such a thing and that were universal. And then it says, my instructions for me are, provide brief explanation of context and relevance of motion. Well, duh. How could it be relevant that a patient would have access to information? I mean, what a preposterous concept. It's 2020, so that's the rationale and the context. So it's something that obviously we have to think about. We're in a very rich information age. And of course, it's not just about the electronic health record in a way. It's what information should we as patients have? Is it an unambiguous good? Are there potentially unintended consequences? And so on. So we have a fabulous foursome here. I mean, I don't know how the Quality Council gets this level of talent to do this, particularly...
They lied to us.
They lied to us. Exactly. That's right.
Lied.
And there are inducements. Let's just say that 20% of your registration fee is going into the pocket.
You got 20 to the winners.
Yeah, they got 20. Exactly. So, without further ado, let me introduce our teams. To my right and your left is the affirmative side. Leading off will be Claire Snyman, a patient partner for Patient Voices Network. Next to her is Dr. Alan Ruddiman, a rural generalist physician. And on the Contra team, leading off will be Jonathon Leipsic, who is now on the...
Cheating already.
I'm just wanting to make sure I have everyone's last name correctly when
Exactly.
when we destroy them.
Well, we'll prompt. You don't have to learn their names. Show sufficient contempt that you don't even care who they are. And then and then his colleague will be Hardeep Chaggar, who is the Executive Director for System Optimization for Fraser Health, and these two have the interesting challenge of the negative. The format is tight, and there is a clock down here. I would urge you all to look at it, because your time will be counted down, and we are not generous on you going over. Okay. So this is 2.5 minutes each.
Like last night.
To begin, 1, 2, 1, 2. Then we will have, which is for me the fun part, I get 18 minutes to tease genius out of all four of them and to create common ground out of the chaos, conflict, and bitterness that will have ensued in the first 11 or so minutes. And then we will try to have a thoughtful discussion. And then at the end, they will each have 1 minute of rebuttals. And then we will get your final vote. And just before we begin, we calibrate the audience, because the winner of a debate, if there needs to be a winner in this new age era, is going to be the team that actually persuades the most people from their initial positions. So please raise your hand if you are inclined to support the motion, being that you agree that people should have full and real-time access to their EMR. Who is inclined to agree with that?
That's good. Really good.
This is going to be like shooting fish in a barrel.
Exactly.
It's going to be so easy.
Exactly. So it's almost impossible.
$20 for everyone who changes their opinion.
And who believes they shouldn't? So it's almost mathematically impossible for them to lose. I mean, this is like a vote in 1977 Russia, like the electoral results going on. Anyway, it's a tough sled, but it'll be fun. Remember too, the disclaimer. We choose the topic and we assign the sides. Nobody that anybody says here is bound to be saying things that they absolutely agree with. So don't assume they're representing what they truly think necessarily, unless they say, I really believe this, and they're certainly not representing their institutions. So everybody have fun, enjoy it, and without further ado, I'm going to turn you over to Claire.
Okay. Good afternoon, honourable moderator, learned opponents, and very kind audience. Show of hands, who believes Canadians legally have the rights to access their medical records?
There we go.
Aha. 1993, the Supreme Court of Canada actually stated medical record information belongs to the patient. Yet 27 years later, we still debate if and how people should access their medical records. As a brain tumor patient, a lack of continuity in data and access to my own medical records almost cost me my life. Luckily, the end result turned out somewhat okay. So healthcare cultures globally are trying to embrace patient and family-centered care, of which information sharing and participation are founding principles. Yet, can we do this when we don't share complete and unbiased information in a timely manner? This is about patient partnership. It's about creating an environment of trust and shifting power. It's also about giving individuals the capacity to create value by having access to knowledge. The research is showing us that individuals with full and real-time access to the EMRs understand their care plans better, they feel more in control of and engaged in their care, they take their medications more effectively, have improved communication and trust with their clinicians, and improved patient safety. Wow. Now that is great benefit to me as a patient and to the healthcare system. There is huge potential in empowering individuals in their care. Let's use technology to enable us to alleviate patient uncertainty and cut frustrating challenges over accessing medical records. My colleague, Alan, and I, patient and physician, side by side, encourage you to support this important cause. We know there are concerns over individuals perhaps not understanding their medical records, being upset by them, or needing access to doctors outside of regular hours. But the research shows us these concerns are unfounded. Also, data and privacy concerns, we know that they are valid, but they are not unique to healthcare alone. Honourable moderator, learned opponents, and kind audience, 2020 is the time to get real about authentic patient partnership and create tangible benefits for both patients and healthcare systems by ensuring people have full and real-time access to their EMR. Thank you.
Fantastic.
Well said, Ben.
Wow. Well done, and in an admirable 1:58 or 2:28, your 2 seconds is magnificent timing. All right.
Well, thank you for the opportunity. I'm but a humble physician from St. Paul's Hospital who was misled to come here and debate this topic, thinking that I would have slides. I said I was going to be in DC earlier in the week. We had a visiting professor that just gave a lecture. I have no slides, and there's not 25 people here, but 1,000. But I'm going to do my best to address the topic at hand. And I want to thank our patient partner, Claire, for both the very eloquent and thoughtful comments, spoken with such an elegant accent as well. But while very compelling, I think it was a compelling argument. Unfortunately, she didn't address the question at hand. And the question at hand is not a paternalistic or maternalistic issue of whether I should control her data. I firmly believe that Claire's data belongs to her. But what is my role as a physician? And I think that the issue at hand is the immediacy of the access of that data. So I'm going to take you back to 1995, where Dr. Jaggar, who's here in the audience, and I took our Hippocratic oath. We took an oath, first and foremost, to serve our patients, to provide them care, to work in their service and treat them with compassion. And I think in this era of automation and facilitated data and augmented artificial intelligence, we're losing the very human aspects of care that have really been the backbone of that Hippocratic oath. Maimonides taught us that we as caregivers are nothing more than that and can be nothing less. So my issue at hand is not whether or not data should be made available to our patients. This is undoubtedly the case. The issue, though, as we get more and more information, the role of the caregiver is to provide care, is to communicate, is to translate, and is to compassionately engage with our patients and our partners in carrying them along their path towards better health, and also through understanding for their conditions. When I started medicine, data was extracted with a stethoscope. Thank God that is no longer the case, because I couldn't hear anything with my stethoscope, which is why I went into imaging. Jug Paul could attest that. But at the end of the day, we now have this overwhelming amount of data, and I think the role of the physician is no longer to extract data, it's to communicate and engage with the patient so that the patients can better understand their information and make their decisions in an informed fashion. Otherwise, we're simply facilitating data transfer, and I'm quite confident that the Ministry of Health should demand a profound refund for my care if that's all I do. We need to be there for our patients. I saw everyone went late last night. Joe Biden was very mad when he was the only one cut off, so I'll let you cut me off this time.
Thank you. It's always heart uplifting when you hear a radiologist talk about the patient relationship.
Please.
So, back to the affirmative. Alan.
So folks, ready or not, we do live in an age of information and health information transparency. So here's a question for all of you. If you've got a smartphone with you right now, I want you to put your hands up in the air and keep it up. Now, if you use your device to access online banking, check in with your preferred airline or a hotel you're staying at, keep your hand up. Okay? Now, if you use it to access your health records, keep your hand up. All right, here we go. 86% of all of Canada's family physicians use an EMR in their office, and in British Columbia, it's actually 90%. But unlike the banking and airline industries, these EMRs cannot routinely be shared with other providers at other locations. Not having this information available to patients then is shown to result in needless retesting, heightened prescription errors, compromised and unsafe patient care, and increased overall healthcare costs. So, providing all BC residents the meaningful integration of a patient-accessible electronic medical record requires an attitudinal shift, a fundamental shift in our thinking. Technology is not the solution. Technology is the enabler. This attitudinal shift will get us where we need to be. Patients have a very unique vantage point. You see tiers of providers and you know instinctively whether or not your care is being coordinated. You know whether you have to provide the same information over and over again, and whether tests have to be done or be repeated due to inaccessible, lost, or missing results. Add to this the 700,000 British Columbians who have little or no access to coordinated primary care support. In fact, perhaps you're one of them, and I hope you now see my point. So as consumers and deliverers of healthcare, we quickly and instinctively recognize that full patient access to EMRs can contribute to fewer medical errors, lowering costs, and way better healthcare. Perhaps some of you, and yes, I do suspect some of my own colleagues, are uncomfortable with vital and necessary reform. Reassuringly, the evidence here at home and abroad supports the fact that this is a necessary transition for the democratization of our healthcare knowledge. Appropriate patient-centered care can only begin when patients themselves are able to access their personal health records and share them with whom they choose to share them. Thank you.
Brilliant. Thank you, Alan, and clocking in at a magnificent 2:22. So,
Hardeep had
Hardeep,
every word prepared.
well,
Someone should have told me.
somebody told you you could actually prepare. Oh, who knew? Who knew?
Here's my USB key.
Who knew? There's the radiology talking again.
Oh. We have a biased moderator here, people.
Hardeep.
Yes, I have nothing of value to add, so they just brought me along for character defamation. I think the first thing I'd like to say is that I love how you compared a compassionate, sector in our purposeful lives compared to banking and going on holiday. So, I think I do agree fully that we need access to our data. I'm all about data democracy, and I stand for that. But I fundamentally disagree with real-time access, and I think that we really haven't addressed that, which is real-time access to our data. I think that one can't debate real-time access to patient records without really discussing the potential risks and impacts of self-diagnosis, right? So, we've all Googled ourselves when something hurts. I mean, I'm not a physician, but we've all diagnosed tumors and cancers in ourselves. And we know that it wasn't true. We've all, thought about our own mental health state, and we've all diagnosed psychiatric disorders. Some of them probably are true. This week, we saw the World Health Organization issue a statement around the coronavirus, and they said that there's an infodemic. There's an overwhelming amount of misinformation on social media and websites. Some of it's accurate, some of it's downright untrue, and that's quoted from them. And Dr. Mike Ryan also said this week, who leads the World Health Organization's emergency program, he said we need a vaccine against misinformation. So my challenge that I have, I do stand for data democracy, but when we start providing real-time access to people right there and then, are we cognitively able to self-diagnose? Are we on Facebook? Are we on Instagram? Are we creating tumors? Are we creating stress in the environment and stress upon ourselves? I think that we should really trust in the physicians and the healthcare clinicians that have life experience in serving patient needs, and put trust in them to deliver the best care. That's what I would do for both myself, my family, and that's what I stand for. So thank you.
Here.
Yeah, nice.
Well said. Very well said.
I have to say, Hardeep, I'm beginning to be persuaded to ditch any interest I have in this. Just beginning. So, those were great openers, and the contours are becoming clear. And we're going to spend the next 18 minutes probing this a little bit. We'll give people an opportunity to go back and forth. So let me begin with you, Claire. So you mentioned that the evidence would suggest that the fears are unfounded, that if I go into my health record and my doctor is written, seems to be acting even more erratically than usual, and is coming into my office with the very bad internet searches about diagnoses, and that I wouldn't lose some trust, that wouldn't affect our relationship. Do you see any risk of censorship that might be occasioned by the free and full and real-time access to anything that a clinician might put in my record?
I think that's a really good question.
Thank you.
Absolutely. Well done.
we're
Well
done
done on
now.
that. Yeah, you're definitely doing your job well there, so thank you for that. I think the risk of censorship around physicians or healthcare teams who are inputting information into the medical records, if they know are going to be available to their patients, definitely would be of concern. However, the research has shown us that the staff that are doing that, for example, the Open Note study down in the US, has shown that when that is actually done, is that is not of huge concern to the individuals, or when they measured it, it's actually not a huge concern to the physicians who are doing it. They may modify some of the terminology that they do, but actually it is not of great essence. And I think it's actually important that when physicians are actually writing things down, that we do not, that they do not look at things that say the patient is a difficult patient. So I think what it does do is it actually looks at how healthcare teams should be actually talking about patients, and I think that's really critical. So what is the language that is actually being used in healthcare records? Because those healthcare records belong to the patient should ultimately be seeing them. So does it actually take it back to the healthcare teams to actually look at what language they are using? Because that could fall into the hands of the patient at the end of the day. So I think good question, but I don't think it should stop the full and real-time access for patients at the end of the day, if that is one of the concerns, no.
So you're saying that it may actually humanize and
Absolutely.
improve in some ways the language used on medical records. So if it does bring you up short, if you no longer would write things in the same blunt and perhaps unkind way, that may be a good thing.
I would say that would be a good thing, but I think at the end of the day as well is that one must remember is people are often hesitant to say, well, I'm not going to write this or this because people won't understand it. I think health literacy is something that needs to be addressed at a much more different level, but at the same time, when a specialist is writing a report, they are going to write it in the name and the vein that they would be writing it. But I think we underestimate what people can actually understand out in the general population. People need those access to their reports. It's really important, and I'm really glad that our opponents are already on the side agreeing that access is important to data. So thank you very much for that. That's fantastic to hear. I'm glad.
But not immediate.
No, not immediate, and that's important. But at the same time, is when you say not immediate, I think what's important to note is that if we're looking for patient partnership, if we're looking for equity, if you have it immediately and I don't, there's not equity, right? And I think equity and patient partnership is something that healthcare systems need to be striving for. Thank you.
Well said, Claire.
Okay, so Jonathan, feel free, yes. Jonathan, you were making kind of, to me, it was a very interesting point. If I've got this wrong, correct me, but you were sort of saying, you know, communication is a great thing with patients. We owe that. Interaction is great. But in some ways, if you rely on just the record and having access to it, it might actually impede that communication because you're relying so much on this record. A, am I putting words in your mouth? And B,
I think what I would, first of all, I wouldn't say that you're putting words in my mouth. What I would reflect upon is, and I think to Claire's point, I think there's a medical record which should certainly be made available to patients. And any testing and any report I provide, I would be happy to provide that with the opportunity to also explain the nature of the results. I think what we're seeing now is not just a medical record that includes breath sounds and weight and body mass index, but rather genomics and metabolomics, and in my case, a complex assessment of atherosclerosis. And frankly, I think that the system and the patient isn't getting appropriate value by having that provided to them in an inhumane or lack of human connection. So I think there's two major issues at play. There's risk. There's risk in the lack of translation. We suffer this even with our physician colleagues when we provide reports. We have to provide different sort of reports for our general practitioners and our cardiologists by nature of what they do. And I think, to me, it's a missed opportunity with regards to all of this evidence to not really engage in it and translate that information in a meaningful way such that it can most positively affect care. I read something recently that was published in JAMA by Eric Topol, who's an expert in artificial intelligence, and I think as we move towards more and more machine learning and more data, the role of the physician is really only going to be two things, and that's going to be the information specialist, and I hope the human element. And I think if we're not careful, one could go to an extreme, and I know my colleagues to the right are not suggesting this, but one could imagine that you would never need to engage with your physician. I provide you your genomic screening, your atherosclerosis burden, and you can just shop around, or for that matter, just self-treat. And I think not only does that come with risk, not to me, I'll find some other way to make a living, but I think that will come risk to our society. I think that will come risk to what it means to be a human, what it means to enjoy and experience the human experience, which is that engagement. And it's a bit rich for me to, of course, speak of this when I know Claire has suffered through having been diagnosed with a brain tumor. And so with great humility and respect that I'm talking about this, I haven't walked in your shoes, but I do welcome the opportunity to engage with my patients in that meaningful, humanistic way that really makes the human experience worth living.
I'm tossing my iPhone away.
Well, I mean, if you're gonna focus on your iPhone for your mental health and your emotional state and your happiness, then I suggest you do.
Actually, I have. And following up on that, I mean, Hardeep, you made a very compelling personal argument that, you know, when you think about yourself and your family, do you want to invest in getting access to this, or do you think a good balanced life and approach to health? Don't get distracted by this, that, you know, yes, you want communication, yes, you want to know certain things, but that's not the key to your happiness. And you were almost implying, I thought, that in a way, this too much information is a bigger risk than presumably not enough, and especially not enough if you can get it another way. So, you want to elaborate on that a little bit? Tell me sort of the existential threat that you think this poses, despite its attractiveness to so many people.
So I'd like to address that in a couple of different ways. Firstly, how many physicians, clinicians are in this room? Can you put your hands up? You know what makes me really sad is that what Claire said is that what I heard was that she wants to send you all back to school for literacy training. I'm really sad about that. Versus trusting you guys in the decades of work that you've done and the experience you've had. I think, so that's the first thing.
Way to play to the crowd. That was great.
So,
we just need a few votes.
So I think that when it comes to fitness and health, we all, we wear Apple Watches, we wear Fitbits, and I think that, basic information like how much sleep did I have to help, me understand what is healthy, what is not when it comes to sleep or exercise or heart rate and basic things like that. I think that we need to train the public and we need to train people like myself for better care in myself. But when it comes to jargon that we read within the medical records that we don't have education on, exposing me to that is huge risk. Because now I'm opening up Google and I'm looking and going, what does this mean? And like I said in my opening statement, everything leads to a tumor in my head and I have cancer. And the stress that puts on me, and so for my child, if I have access now to my child's medical records real time, the stress that it's putting on me would be immense as a father. What I really want to be there is a champion of the medical professionals and to be able to provide the compassion and love for my child in supporting them through their journey versus becoming a pseudo doctor overnight, self-diagnosing with access to those records. So that's really where I think the balance is between having real-time access to data on my watch for me versus having real-time access and trying to become a pseudo-doctor overnight.
Oh, very intriguing argument. So Alan, you're a doc, you're a GP?
I believe I am.
You are. And, we've heard for years the frustration that physicians have had when we started doing what Hardeep said we do. We go to the internet, we think, look, I saw that study from the Northwest Texas Medical Journal that suggested that vitamin D will cure my cancer. Why are you giving me chemo? Et cetera, et cetera. And it was hard to deal with. I mean, we've heard that. So are you at all worried as a practitioner that this would be a bit of a burden? It creates additional complexity. It does tax your communication. You may have to spend more time undoing my interpretation of my record if it's complicated and so on. Mm-hmm. Is that a concern?
Fundamentally, I think that's a fantastic question. And if you asked me the same question 15 years ago as we were transitioning in British Columbia to electronic medical records, I had fear that people would be knocking my door down, walking in, and sure enough, it arrived. People arrived with reams and reams of paperwork. But what you do is you have to manage the meaningful change. We're talking about the democratization of knowledge, sharing people's health information with the person that matters most, the patient. And if we're not giving patients access to their information as they journey through the 24-hour clock, they journey through the week, the risk is that they're not appropriately prepared. The profession is adapted very, very well. We've had the highest uptake in Canada as a province for physicians and nurse practitioners using electronic medical records. The problem is, when you leave the office at 5 o'clock and you lock the door, you wave bye to your 1,000 patients. You've secured them for the night. And then your patients drive up and down the road past the clinic going, when can I see my doctor again? And I don't think that's where we need to be. Guess what? The reams of paper that people were printing out stopped when my staff and I engaged with the public and said, look, we're happy to engage on the information you're seeking. Here's the 10 accredited websites that we look at in the office amongst the staff and the physicians as we think about the quality of your care. You print from those websites, we will carve out the time. We manage that expectation over time, and what it's done, it's grown a longitudinal relationship between the clinic and the patients that arrive there. So the fear and worry, Stephen, 100% 15 years ago. In the digitalization and the democratization of knowledge, the place we live, we're all more connected than we ever were before, but if you're not connected to a longitudinal care provider, we're never more distant. So somebody has to be able to, as Claire says, help with the health translation. Who better to do that than your primary care provider?
Great. So, indeed. So, fantastic responses all four. Now I'm going to turn to both sides, and you can nominate your who speaks to this. So to make this more concrete, give me an example, either one of you, where you think, if we have this, when we have this, here is the concrete benefit. I mean, never mind that it's a right, never mind that it's part of the partnership, but concretely, give us an example of what might this do for my health as a patient. Give me of how that would work and how that access would actually get the job done.
Could we take that on together? I would suggest Claire give you the patient perspective, and I'll give you the physician perspective, and we'll see if it gels.
Yeah, sure. So I brought an example of what my medical records look like in paper, right? So I will, for example, I have a team of probably, let's say, 7 specialists, and you're totally right about when the doors lock down, I don't have access to some of the medical records that I need. I think a concrete example of me having access to those medical records is, for example, I may have had some blood tests done. I'm able to go into my e-health and actually access those blood tests and see if some things are out of whack. What that enables me to do is actually, yes, I will go onto Dr. Google for sure and have a little look at what that means. I'm not a doctor, so I will not be able to go, oh my gosh, I may wander down a little bit of a dark vortex and go, oh my gosh, it could be this. But what it really enables me to do is, number 1, I've tracked what's going on. Number 2, I can educate myself a little bit about what it could potentially be. But what I really do is I put down some questions about what I'm going to ask my GP. And I have a longitudinal relationship with my GP of 13 years. So I set down some questions I'm going to ask my GP. And that is my way of managing my health. So when I am able to go in and make an appointment with my primary care physician, I then go in and I'm able to sit down and have a conversation with her. It opens up that balance with my physician when I go in. So it is an open dialogue. I've got a communication channel. I've got trust with her. If I hadn't had those blood tests in front of me, I would be walking in. She'd say, this is it. Okay, it looks fine. You can go out. I wouldn't have had that preparation, that time, that ability to think through and ask my questions and be educated. I'd be walking in cold stone. So I don't know, that's how it works for me as a patient. I don't know if you have anything to add from your side, how that helps you.
Yeah. So a very quick insight. Back in 2004, Interior Health embarked on a process working with the physicians in the South Okanagan, whereby as they were launching Meditech, so they were integrating an electronic health record into the hospital, they asked the providers in the community, would we provide a summary from our EMR on the 100 highest vulnerable patients in our practice? It could be frailty, it could be a cancer diagnosis, it could be somebody with substance use, mental health, and addictions issues. The idea was, with the patient's permission, to push that information from the clinic into the hospital. We reduced unnecessary emergency department admissions by almost 20%, just by having at least some real-time access to a summary from the family doctor's office. So here's where I really believe this is going to be powerful. We will get over as a profession the worry and the angst about the record gets opened up. It is not my record. I am the custodian of the computer system. It's Claire's information. It's Claire's record that sits in my computer system. It used to be a filing cabinet. Claire would have to print it off to take it with her. We can export that with Claire's permission when she needs it. So 3 days ago, Claire comes in to see me, and I put her on a very strong antifungal drug. I go away for the weekend, but Claire arrives rather sick at the emergency on a Saturday morning. It's critical that if she can't communicate and we can't find the information about the drug that I've put her on, that somebody knows about it. So we'll go digging around. If that information was available in emergency, Claire's out of trouble really, really quickly because we know exactly what she's doing.
Thank you. And final question to you, gentlemen. You've raised some really interesting issues, and there is, knowledge always has a potential misuse. So, again, if you could give us an example of where you think it could really go off the rails, and do you think it is plausible to mitigate that you could have the best of both worlds, or you say, no, it's too big a risk, it's too big a distraction, and it won't work? So,
can you take a split approach
sure,
on this?
Sure.
Yeah. So I think that what the picture Alan and Claire are painting is very theoretical. The reality is we don't do research and then write down 3 questions we want to ask our physician and then book an appointment that's available. The reality is we stay up all night. We search, we search, we search, we search. We cry, we worry. And then what do? We can't get an appointment. We walk to the walk-in doctor. We sit there for hours. We don't get the right answer. So then what do? We go to we don't know where to go in the community health service. We go to the emergency room. So what do? We create congestion. It's the wrong way. We have to be more responsible in providing care in a better way. And so simply releasing all the records to me real time and expecting me to have a great result for myself is not the right way.
I would just, if I could reflect maybe in a somewhat different light, I think the issue, the way it's being painted, is almost as if we're taking a paternalistic or maternalistic approach to the patient record. I think the word you used, Hardeep, just a moment ago around service is really the key one. The question is, what is the role of the healer? We're here on unceded territory of our Indigenous and First Nations people. And what we're talking about now is providing more and more data without reflecting, in fact, on all the lessons that we could be learning from these people about healing, about community, about the engagement between the healer and the patient. And I don't think any of that is possible without engagement. So my question around, or my debate on this, is not around providing Claire or any other patient unfettered access to their reports. The issue really is the immediacy. And I think we have to be very careful if we move to a point where, like my children, they can get any type of food they want without ever actually seeing the person procuring it, the person cooking it, the person that put their energy into it. So one could imagine you could simply have the test ordered, ask me to co-sign it, and simply ingest the information and never engage in that opportunity to communicate. And while it's not my role to ensure that the communication happens, and that would be paternalistic, I think that'd be a real shame for our society and the patients that we serve.
Well, thank you all for a very stimulating 18 minutes, and we are now going to get to the final rebuttals. These are 1 minute each.
I thought we were done.
No.
That's all I got.
They just put like before. Yeah.
What am I going to say now? Yeah.
The opening minute to
Okay, thank you.
last one.
So the research shows us that full and real-time access to EMRs is beneficial for patients, especially actually the most vulnerable. Yes, there are challenges to implementation, but none actually so big, I think, that should overlook the challenge of being a patient with no limited access to your medical record. I think it's time to look at taking the fear out of authentic engagement with the communities being cared for, and to look at ways to create productive partnerships and to reap the benefits that technology can enable. So I'd like to say from this patient here to those working in healthcare authorities in the room, to look at ways to help me break free of these handcuffs, of uncertainty, of frustration, of challenges, and of heavy binders of paper medical records, and allow me to have the right to contribute towards helping create a more sustainable healthcare system by creating value, by having access to my knowledge and to my medical records. This really is the right thing to do. Thank you.
Right. Yeah, props for the prop. That was outstanding.
Well, again, I want to thank everyone for the privilege and opportunity. It's obviously an honor to be here and to again, refocus on the debate, because my esteemed colleague is very eloquent, but again, she seems to be distracting from the topic at hand. To me, really, the topic is not whether or not we should unshackle our patients from being restricted from their information, because clearly we need to. I'm the first one to believe in that. I believe that the data and the patient record belongs, as Claire would suggest, to the patient. I think what we need to do, though, is we need to tread carefully, because we're seeing a rapid evolution in our society in a fashion that I think we will lose the one thing that really makes life worth living, and that is the human experience. I think that if we automate everything to the point where human engagement between the healer and the sick is no longer present, then I think that's a sad day. And I think that we'd be fooling ourselves if we didn't think that there would be many patients who would simply avoid going to see their physician if they were in receipt of their data. Now, their data, as is being spoken of, is an evaluation. What we're speaking of is, of course, hard data that may be ingestible at all times. I don't go see my banker, I get it online. I don't go see my insurance guy, I get it online. Thank you.
Thank you. Your final minute, Alan.
So the evidence does show that the more patients experience the benefits of accessing their EMR and trust that their privacy is being protected, the more they use and benefit from the EMRs. So how can we ensure then that this transparency itself will be beneficial to all of us, patients and providers? So first, I believe medical and health education at colleges and universities should equip trainees to manage information sharing with patients so that the patient-centered experience is comfortable and as usable as possible to all of you. Second, physicians and healthcare organizations need to be better prepared to participate in protecting the privacy and security of that health information. And then third, we need to support patients make sense of their health information, as Claire has suggested, to better care for themselves. Engaged patients have way better health outcomes. So we should all view patient-accessible EMRs positively. They support improvements in health, improved quality and efficiency of care. Just go back and look at the research. And they also help reduce healthcare costs. Thank you.
Thank you. Hardeep, the final word is to you.
Yeah, thanks for having me here. I really appreciate this. So I want you guys to picture a 6-year-old boy. And that 6-year-old boy suffers extreme childhood trauma, being beaten by his father, abandoned by his mother. That child then further goes on and joins the military at the age of 18 and suffers extreme racism. And he gets to the age of 40 and wonders why he doesn't have a relationship with his own son. So he becomes suicidal. He gets diagnosed with complex PTSD. And sitting in the counselor's office, he pours his heart out and says, these are my problems, these are my challenges, I don't know what's wrong with me, I feel like I'm normal. The counselor takes all the notes. And at that moment, the counselor gets up and he goes to the toilet. And the patient reaches over, grabs the book, opens it up, and reads the diagnosis of what the problems are with that person. That person was me. And I jumped in front of a train. Because they did not help me reading what was wrong with me. What I needed was the care of people like yourself. That is what I needed, not to know how to self-diagnose. That is my closing statement.
Oh, thank you.
Obviously gave a big hug.
Well, fabulous job as always by our debaters. I think you really outdid yourselves with creativity, and there were some good amusing moments, but also some pretty profound things. So now it's time, audience, to express what you thought of this. So you 11 people who were inclined to agree with the gentleman to your right, who essentially have said, you know, this is the sloppy first draft of my health status, and it's not worth reading the rough drafts. We don't need instant access to these records. But now, do you now agree, because of the arguments of the affirmative, that actually I'm persuaded I want that real-time, full-time access? So if you were for the negative, has anyone switched to the affirmative that you think this is a good idea? One person?
The 11.
All right, well, that's 10%. That's a good, that's astonishing. Okay, for you other 1,040.
Now there were 25 in this room when
Exactly. Were any of you persuaded by the eloquent and sometimes poetic argument of the negative that despite the intuitive appeal of this, that there is a dark side to this, that somehow it may be part of the general move towards an over-technologized, super-saturated information era that will harm us more than help us? I'm trying to do my best for you guys. Did any of you change your minds to support the negative?
There's a couple of hands.
Hey, not bad.
Wow, interesting.
Not bad.
Listen, I would say
Well done, guys.
you each changed about 10%. So I'm going to declare this a phenomenally wonderful draw.
Wonderful. Well played. Well done, Claire.